Okay, well, yesterday's video left off with TIVA by CRI, which is an anesthesia that is done completely with injectable agents that you continuously give IV. The other way that we can induce anesthesia um, is to use an inhalant by itself. So this is not using an injection. So if you get a dog out, you put them directly on a mask and you turn on the ISO or the sevoflurane and you give the inhalant and they inhale it until they fall asleep. Um, Now, this is faster than IM, but slower than IV. So if I'm going to compare, fastest is IV, then would be inhalant, the least fast is the IM. And similar for recovery. It's usually faster for IV, a little bit slower with inhalant, and then IM would be a slower recovery. So you have to understand, sometimes we choose these methods of induction based on patient factors, the type of procedure. I will tell you, sometimes we do mask induction if we have to pull a couple stitches or cut an ingrown toenail or take some x-rays. The nice thing is you can control how deep they are by turning the dial on the vaporizer up or down. Now, it's not super fast. There is going to be a slight delay with them going from light to deep. Now, what factors can affect this method of induction? Respiratory drive. If they hold their breath, they're not going to go to sleep. If they're breathing very shallow, it's going to take them longer to go to sleep. What is the agent you're using? What is the flow rate that you're using? The breathing circuit. So all of these can affect how fast or slow they're induced. Now remember, sevoflurane is going to be faster. If I asked you which agent would you prefer for a mask induction, I don't want them to be stressed out. I'm probably going to pick Sevo. ISO is fairly fast, but if I had a choice between the two, I would pick Sevo. If we look at the chart here, you can see in about 5 minutes or so, and this patient factor, sometimes patients are pre-medded. I will tell you, I prefer to do mask inductions. Chamber would be similar to mask on a pre-medded patient so that they're already relaxed a little bit. So now you mask them till you can open their mouth and pull out their tongue, and then you intubate them, and then you keep them on the ISO or Sevo. They get a little light. You turn up the gas, they start to get too deep. You turn down the gas, they start to wake up. Doctor says we're done, and then we have about maybe a 15-minute recovery time. Remember, with inhalants, they exhale. That's how they metabolize or get rid of ISO. It doesn't really go to the liver or the kidney. So they just have to exhale it. I will tell you that this timeline does not take into account if you use a pre-med. So if you gave them like an ACE or butorphanol pre-med, this could be longer because they'll get rid of the gas, but they will still be sleepy from the pre-med. So that factors in. Now, the most common that I've talked to you about is to give an IV induction, put a tube in, and then maintain them on a gas. So you're getting pros and cons of both. So the pro is this is rapid. You get that quick IV induction. You can control how deep they are by how much you give. And they can recover fairly quickly. If I look at the chart, they go to sleep very quickly. I intubate them, hook them up on the vaporizer, all of a sudden, and these are important notes to read on these charts. You should be reading all these little notations. Patient is light, you turn up the vaporizer, all of a sudden heart rate starts going down, respiration starts going down. You're like, maybe I should turn them down. They start to come up. Doctor says we're done. You turn off the gas and they start to recover. So this is probably the most common that we will use. So for all of those different methods, I want you to tell me pros and cons of IM induction, IV induction, TIVA anesthesia, which is all intravenous, TIVA by CRI, inhalant induction, and IV2 inhalant. Those are all the different forms of induction. Now, some of the things that you need to have a checklist of what materials you need for induction. So you want to get that all ready. Like I said, normally what I do is I get my patient in, history, blood work, talk to the veterinarian, calculate drugs, give them their pre-med while they are falling asleep. And normally we give the pre-med IM while they're going to sleep. Then you can get all your equipment set up. And what do we need? Well, any syringes, needles, drugs like antibiotics. You might need some more pain meds. Get your fluids all set up. Make sure you prime your line. No air in the line. Anything to prevent hypothermia. So set up the heating pad. Get some towels. Maybe hot water gloves. Okay? Now, you want to set up your anesthetic machine as well. And remember, you're going to have an anesthesia machine in the prep room, and you're going to have an anesthesia machine in the OR. So usually the anesthetist has 2 machines to set up. So you're going to have all the equipment for both machines. Rebreathing systems. Now I want you to, a rebreathing system is used for patients 15 pounds and over. So you don't want to look at these weights. Non-rebreathing systems are 15 pounds and under. Okay? 15 pounds and under, non-rebreathing, 15 pounds and over, rebreathing system. One thing to add in your notes, and this is sometimes you might want to pause the video and write these things down. Some clinics have 2 types of breathing systems. They have a rebreathing system. They have a pediatric rebreathing, which is 15 to 30 pounds, and adult rebreathing, which is 30 pounds and up. But if your clinic only has 2, you would use a rebreathing system for 15 pounds and over. But remember the type of patient. I mentioned this in one of our lectures. You have an 18-pound dachshund mix or whatever. So they're technically over 15 pounds. That puts them in the rebreather, but they're overweight. They probably should weigh maybe 13 pounds. They have the lungs of a 13-pound dog trapped in that 18-pound body. You're going to want to probably put them on a non-rebreather. You can always switch, but you have to think about, you have to make it easy for them to breathe. So the best choice is to go closer to their ideal weight. The other thing you always want to know is where your crash cart is and the equipment. So when you guys are in surgery rotation, there's 1 in the OR and there are 2 in the prep room. At VCA, they have these little kits in surgery. You can take one into surgery with you. The nice thing at VCA is we print out an anesthesia sheet for every patient, and it automatically calculates their emergency drugs. So in their chart, if I had an emergency, I can open up the chart and I could be like, that's the atropine dose. But you have to know where the atropine is. You have to know how to access these drugs. So make sure you're familiar with all of these locations. For critical cases, I used to write the emergency drugs on a big piece of paper and tape it to the wall. So I wasn't like fiddling on a little line. I look at the sheet on the wall, that's my emergency drugs. Okay, so I've already kind of talked about this, but the reason that we pre-med or sedate is to calm them prior to induction. We want sedation, cholinergic blockade, which is basically, if we want to give anticholinergics, we want to block what the cholinergic system is doing. Talk about that fight and flight. Analgesia is given ahead of time. Also, pre-meds and sedation is going to relax the patient. You imagine a dog is tense, or a cat especially is scared. They're going to be much more relaxed if they have a pre-med prior to anesthesia on board. So remember the drugs in the categories: the tranquilizers, the alpha-2 agonist, which is your dexdomitor, xylazine. Tranquilizers are acepromazine. You're also in the tranquilizers is your benzodiazepines, midazolam, Valium. Ketamine can be, remember, used as a pre-med. We use it usually with Valium for induction, but you can give ketamine pre-op sometimes. And your anticholinergics. And remember, why do I give an anticholinergic? To prevent the cholinergic effects, the drooling, the bradycardia. Okay, so normally the reason I give atropine for a pre-med would be I'm worried about their heart rate being too slow, vagal stimulation, or excess salivation. So this is very important. When you give the pre-med, you want to put them in a quiet, preferably dark, now not pitch black, because you have to keep an eye on the patient, but you want to put them somewhere where the drugs will take effect. And I will tell you, a lot of clinics have a cage right in their main treatment room, and they put the dog in there, and everybody's walking in and out and doing treatments and talking, and it's going to take longer for that dog to be sedate. So hopefully you have a quiet room where you can let the drugs take effect. So stimulation and excitement may hurt the effects of our drugs. Now, once we see our patient is adequately sedated, then we're going to get ready for induction. I will tell you, that'll vary. I've seen some dogs in 5 minutes look like they're ready. I've seen dogs take 30 to 40 minutes. It's going to depend. Now, induction is when we go from conscious to unconscious. When we go from that stage 1, remember we're going to pass through stage 2 and go to stage 3. And we want to do it as smooth as possible. You technically intubate in stage 3, plane 1. That's when they first lose their swallow. But they're probably still blinking a little bit. They may still move their paws, but they're just about unconscious enough to let you put a tube in. Okay? IV induction gets you through the excitement phase the quickest. IM induction usually goes through it. You will see some excitement phase if you mask induce. I will say that. The excitement, and there's a note there, excitement is usually seen with Inhalant. IM is pretty smooth. And very rarely do I see them get excited with IM or IV. So be familiar with which protocol do you see which effects with, okay? Now, let me go back to something with intubation. Intubate while the animal is still light. Sometimes you go to put the tube in and they're trying to swallow. Don't ever force the tube. You may have to give them more drug. You can cause trauma and irritation. So you want to try to pass it when they'll just allow intubation, but they're not overly deep. But if they fight you, you're going to have to give a little more drug. So these are the induction drugs that we can use. Ket-Val, or you can do ketmidazolam, propofol. Neuroleptal analgesic would be like fentanyl and Valium. Neuroleptal analgesia is an opioid and a tranquilizer. That's what that means. Thiopental sodium, which is pentothal, we don't use anymore, but you still need to know it for the board exam and such, but that is an IV induction. Etomidate. The other drug you should put on here is Alfaxan, ALFAXAN. That's another IV induction. Now remember, Tilazol is an IM induction. That's the benefit of Tilazol, but it can be given IV. But if you're going to do that type of protocol, you usually use Ket-Val. Every time we've used Telazol that I've ever used it, we go IM. So you're going to give it to effect. Don't give the entire dose. Kind of let, see what the patient does. 1 second. So again, when you give, you're going to give to effect half your calculated dose. Wait to see how they respond. Sometimes I have to give all of it and a little bit more. Sometimes I get away with giving half. So the way we typically do this is you're going to titrate, give to effect, and it says a series of boluses. What that means is I give a little, stop, give a little. Now, important to note, IV induction gives you 10 to 20 minutes of unconscious anesthesia. But if you're going to go on to a spay, a dental, a surgery, you have to intubate them and get them on gas. So when the IV drug wears off, the inhalant kicks in. So all it's saying there is if all you use is the IV drug, you get 10, 20 minutes. So if you need more than that, it says here, you either can give more IV drug or put them on an inhalant to keep them asleep. Inhalant induction, isocevo, because they have that low blood gas solubility, which means they're quick induction, quick recovery. They will go through stage 2, but it's faster. Mask induction, one thing, this is an important sentence, don't restrict chest excursions. That is them trying to breathe. I've had people laying on a dog holding a mask, but then the dog can't breathe. If they can't breathe, they're not going to take in the gas. So watch very closely. Also, sometimes people shove the mask on their face and shove the cone into their eyeballs. So watch how you're holding the mask. Watch that you're not too tight on the patient, okay? Now, I will tell you, when an animal is on a tube, on gas, they usually get 1 liter of oxygen. When you mask, you need 3 liters of oxygen. 3 liters of oxygen with a mask. So you'll have to add this in to these notes. It's just you have to fill the mask. You have to get them anesthetized. What are the downsides to face mask? So this is slide 26. Very important to know why there's downsides. Exposure. Even though that mask looks like it fits, there's always the potential for some leakage. So you might smell some gas. You have to be cautious. When a patient struggles, this is a very stressful induction. I'm not a fan of mask inductions. They can be very stressful. Patient releases epinephrine, which is fight and flight, predisposes them to arrhythmias. So you want to try to have a calm, sedated patient as best. You can just mask them with no other drugs on board, but you're going to use a lot of gas and there's going to be more struggling. So if you can give a little sedative, then mask them, it's going to be much better. As soon as, and the other thing, it is a longer induction. If poor respiratory function is a concern, this is not a good induction. I would not mask down a bulldog. They have a hard time breathing anyway. So trying to get them to inhale, the inhalant is going to be a challenge. Cats, it's going to be very stressful. So as soon as they go to sleep, you want to try to get an airway as soon as possible. And make sure, again, don't compress the chest. Also, don't push the mask where it covers the nose or pushes into the eyes. Now, a chamber induction, if you remember that box, it is filled with gas. This is usually for patients that are about 15 pounds and under, for small, so exotics or aggressive patients. There are 2 ports, if you remember, on each side from your equipment lecture. One infuses gas, one gives away for gas to escape. So there has to be two ports. You put the cat in the box, close the lid, they start inhaling the gas. Again, this is very stressful. So what's the issues with the chamber? Stress, vomiting, blockage. Like if they fall asleep in the corner, you have to watch their positioning. You cannot feel a heart rate. All you can really do is observe their eyes, watch them breathe. That's the only way you can really monitor your patient. Now, you will have the hose that's taking anesthetic gas out, but when you open the box, all of that gas is going to come out. So there is going to be exposure. It's almost impossible to prevent that. So you just want to do it in a well-ventilated area. If you're pregnant, if you even think you're pregnant, you don't want to be doing masking or chamber inductions because there's just a lot of exposure. So you have to be cautious. And again, epinephrine release, cardiac arrhythmias, so the stress can predispose the patient. Oh, one note to put on chamber induction. You need at least a 5-liter oxygen flow. So an intubated dog is typically on 1 liter, a masked dog is on 3 liters, and a chamber animal is on 5 liters because you have to fill that box and maintain a concentration. So you're going to run a much higher, you would never run like 5 liters on an endotracheal tube. And if you run too much oxygen on a mask, their cheeks blow up. So you have to be very cautious. Now, IM induction, this would be an example, would be Kitty Magic. So that is not on the slide, but the Kitty Magic is an IM induction. So it's typically a combination of drugs. Tranquilizers, it could be a dissociative, could be an opioid. Like Kitty Magic, to remember, is ketamine, dextromethorphan, and butorphanol. You put all 3 in a syringe, you give it IM, put them in a cage, in about 3 to 5 minutes, you can sometimes put a tube in their throat. They go to sleep that quick. Tilazol is an IM induction. Midazolam and ketamine can be an IM induction. So the advantage to an IM induction is if you cannot get an IV injection. A very, very young animal, but this is my #1 reason: aggressive animals, captive animals, wild animals. But like, you may have a really sweet cat and still decide to do Kitty Magic, and it's a very nice cat. But IM inductions are good for cats. I like them because you can put the catheter in after they're asleep. Sometimes we even draw blood. That's not ideal, but if we have an aggressive cat, we will get a shot in the muscle and do nail trim, blood work, all that stuff when they're asleep. So you can do that. Now, if we're talking like a zoo, we're talking tranquilizing gun. We have to get sometimes creative with IM inductions, rabies poles, squeeze cages. But you just want to make sure, and I will tell you another tip on IM induction. The epaxial muscles work better than the semimembranosus tendinosus. They are better than the back leg muscles. I prefer the epaxials. I think there's a better blood supply. They go to sleep faster. Just a preference. So what is the difference between an IM or an IV? Big thing to remember, your drug doses for IM are always higher than IV. It's not always twice the dose, but it can be close. So IM is always higher, and you need to know why. Because it has to go through the muscle. Some of that dose is going to be lost, so it's going to be more. IM induction takes a little bit longer to reach the brain and achieve that effect. And if the IM induction is reached and we still need drugs, You either have to give a little bit of inhalant or a little bit of IV agent to get them fully asleep. And then IM induction is a longer recovery. IV is faster. So be familiar with some of the differences, IM versus IV. And like I said, a lot of times if I've got a patient that's trying to attack me, I'm going to give an IM induction. A very sweet old cat, probably going to be IV induction. So a lot of times the patient factors is why we go IV or IM.